All right, folks, we are back. I'm your host, BKP, and we're at Circuit World here in Blue Ridge, Georgia. And we have Dr. Whaley and Dr. Raymond Tidman here with us. And it is time for Ask the Doc. We always thank Georgia Cancer Specialist, Northside Hospital Cancer Center for this segment. We always have 2 questions every morning. If you're new to the show, that Dr. Whaley spends a lot of time, energy. He has graphs, charts, algorithms, survival rates, you name it. It's going to be on the screen. Take it away. How are you today?
Well, it's going to be more talking time today because we have 2 simple questions. But everybody's ever watched us for a long time. My wife says if you ask Bill Whaley what time it is, he tells you how to make a watch. But
yeah, but you know what? If you show him,
ask Ray Tidman, he drops the watch. So.
Don't steal my punchlines.
All right.
Hey, we'll let you know when to come in. All right.
Okay, now wait a minute. I got just 2 things for you. Real men wear pink, and I'm all bundled up because, as he said in his opening, it's raining out there, folks, and we have 3 seasons in the mountains up here. And I told you what that guy said about moving to the Ukraine. That it was only 2 seasons of the year, and then they didn't have any springtime. And so anyhow, we have a springtime, and this is it. And so if I blow my nose or rub my eyes, it's because of pollen, and it's raining out there. Yeah.
Producer said to me when we started this morning, he said, I'm sniffling a little bit.
Yeah,
so,
right. And so it's not Omicron. It's pollen up here now, right?
So.
All right. So listen, the first question here, I really have a lot of sympathy for the patient and for the wife, and Ray deals with this every day. But this is a woman who is writing about her husband. I am worried about my husband, who is obsessed and anxious over a diagnosis of chronic lymphocytic leukemia. He has had this for 6 years and was diagnosed at Mayo in Florida. Was told that he was stage 0 and he needed no treatment. We are now living in North Georgia, and his hematologist says he still does not need treatment. Now, we've gone over CLL so many times that chronic lymphocytic leukemia is one of the processes that can often be detected just by when you're doing a computerized blood count in the PCP's office. There's an increase in lymphocytes percentage, nothing wrong with the blood count. Send it off for flow cytometry, and it says that it's monoclonal, and technically then that's a malignancy. So that's what this guy's got for 6 years, and anything happened. Now here's the point that I really think we've dealt with this before, but he is lean and fit, and he has no other diagnosis. Well, she doesn't say really, but I got the sense from that he's not taking cholesterol drugs. Wouldn't you say that, Ray? Probably not on medicine. The hematologist ordered a CAT scan because my husband demanded it, and I feel sorry for him, but we do tests like that periodically because somebody just drives us crazy about it. And you have to, if you can find this ICD-10 code that will allow you to do it, then it gets done, right? So I feel for the poor hematologist nurse who probably was feeling all this. So the hematologist ordered the CT scan, and there was a calcified coronary artery. Well, we talked before about these for-profit on the radio and television, come get your CT scan to study your calcium score. That is a very worthwhile test. Not the CT scan of your total body that says I'm going to look for early cancer. But so they did this, and clearly there was nothing wrong with it. It was not done for the purpose of the calcium score, but they're able to read the calcium score. And the hematologist told him it should be evaluated by the cardiologist. Now, perfectly normal, right?
Yeah.
He's resisting that. So here's a guy who kind of is obsessed over this disease that didn't bother him, hadn't bothered him for 7 years, and here he has a high calcium score. We're going to talk about this in a few minutes. But he is resisting that. What do you think he should do?
Well, let me jump on that because that's really my area.
Might be able to do here.
Before, yeah. and you're going to get into the calcium scoring and the usefulness of that, so I won't go there. But basically you have a fellow that's really focused on something and he's anxious about it and he's saying, something's wrong, I need to know. And you can, as a physician, you could take two approaches. You can say, well, ain't nothing wrong with you, let me just reassure you. Or you can say, well, clearly your intuition is telling you something's wrong. And you're focused on this diagnosis. Maybe we should just listen to your intuition and say, would you please go figure out what's wrong? Because something's wrong. I mean, you're anxious about something, and most people don't get anxious about nothing. I mean, you don't have a lifelong history of being an anxious, troubled person that's neurotic. You're anxious. So maybe an inventory, maybe you need to sit down quietly or talk with your wife or go on some long walks and figure out what you're upset about.
Right. So a lot of times heart disease gives people a feeling of impending doom, and they're not having chest pain. Now that's way back in medical.
So, but the bottom line is say, look, let's
not quite right.
Let's trust your feelings. Let me validate your feelings. I don't want to minimize them, but let's expand the horizon here. Your oncologist is saying this is okay. Don't worry about this. So what else is it? So then.
Okay, so this is going to be kind of quick because we've done this so many times. Put up that first one there. BKP, you remember we went through this here, I think about maybe 2 or 3 months ago when we talked about chronic lymphocytic leukemia. This takes the period of the last 50 years, I guess, where the way you classify this disease continually changes. The last one on the right-hand side is really the last place at which specific genetic markers for chronic lymphocytic leukemia were identified, because that's been kind of easy to check. But if you'll notice, way back here in 1975, they classified this based on your age, your sex, how high was your white count, and things like that. When you get over here now, the only thing that they're classifying this with, in addition to age, because that's very important, is every one of these things on the right-hand side is a genetic test. Right? See that? Those are all gene tests. Pull that down now. Now, we showed this a few months ago. Got the next one up there? And I said, now this is statistics that make you want to say, well, you can prove anything with statistics. But these on the left-hand side here are those genetic modifications over there. You're right? Now, these two at the top, when you look at median overall survival, look versus down at the bottom, normal, before you have to do anything, is greater than 10 years. Okay, up here you start having to do something in 30 months. So that's less than 3 years. But if you look at, that's why statistics are so funny. If you look at this particular genetic aberration called the deletion of the 13q chromosome, you don't do anything till 2.5 years after the normal one. And this one here is about 4 months past the normal. And you can pull that down now. So what I'm trying to tell you is, although there are genetic markers there, some of those genetic markers are actually associated with good stuff, kind of like the HER2 neu and the breast cancer. Make sense, right? Mm-hmm. Okay. So we got those two things out of the way. Put up this next.
That's an algorithm.
All right, we're going to go to.
Told you we'll have one. We're going to have a survival curve.
Yeah, we have 2 algorithms here. All right. So first algorithm, it starts like initial management of chronic lymphocytic leukemia. That's really kind of complicated, isn't it? Goes way down here. But the only thing that it really gets into at the very top is, do you have those 2 genetic markers at the top that are adversely affected with everything else? Pull that one down. But anyhow, come down here, and when you get to here, it says targeted therapy, targeted therapy. There's no chemotherapy in this algorithm. The reason I've got this next one up here, this says got the next one? Selection of second-line therapy for chronic lymphocytic leukemia. You remember that we talked about testicular cancer, and the fact that now testicular cancer has such effective treatments that basically 75 or 80% of the people who have advanced testicular cancer diagnosis are totally cured by the recipe of chemotherapies that we have. Pull that down. There are enough immunotherapies and genetically directed therapies here that most patients when you're taking everybody with that funny blood test with chronic lymphocytic leukemia is going to go out here and die of something else, kind of like prostate cancer patients. So your husband is in this category. Leave him alone. So now we're going to the next one. Coronary artery calcium scoring and outcomes with statin therapy. What's that?
Survival curve.
Survival curves. All right. Now, these survival curves are different levels of the calcium score, and when anybody's got an elevated calcium score, even if they have a normal cholesterol, they get a statin. Pull that down. But what that shows you
And what's a statin? Because
go ahead, Ray. Tell him about the statin.
Statin is one of the most commonly prescribed class of medicines in the market. There are two groups, water and soluble and oil soluble. Probably, I don't know, maybe there's 8, 10 of them.
Lipitor, that's the first one.
One Zocor, Crestor.
Right,
There were
Crestor,
other ones
Lipitor,
first,
right.
but Lipitor
But anyway, so they're very commonly prescribed. There's a lot of internet stuff about, statins can do certain things that is a fair amount of hooey. But statins can cause problems, so I don't minimize that. Statins have probably cured more heart disease than all the cardiologists in the world. They might not want to hear that.
There you go.
But statins are a very effective medicine.
All right, I'm going to give you.
Back to you.
Okay, all right. I'm old. All right, so I was riding in the Boston Marathon at the time that the Framingham study was reported that showed that high cholesterol associated with death. So when statins first hit the market,
He was running beside Paul Revere.
I ran beside Jim Fix.
He's dodging horse crap.
Yes, sir. So when statins first came out, the first thing they showed was if you have if you have coronary heart disease and take statins, it lowers your mortality by 40%. Second chapter of that was if you give it to people that have an elevated cholesterol, it lowers their fatalities by 40%. Third was that if you show that they've got atherosclerosis, give them a statin and drop their LDL below 70 and go back, some of that plaque was dissolved out. At that point, many doctors began taking cholesterol-lowering drugs who had normal cholesterols. Well, the natural outcome of that is then give statins to people with normal cholesterols. And what did they show? It reduced their mortality by 40%. So as Ray says, the cardiac death, if you start taking statins early, will lower the chances you're going to die of a heart attack by 40%, regardless of which group you get into. Show that last one then. So see all of these little sub things over here? Reason I showed that was homocysteine is in here, and there's about 97 other things besides just the cholesterol, you can pull that down, that affect the long-term outcome of whether you do or don't get heart disease. So that's the reason that even if you have a normal cholesterol, total cholesterol, and have a calcium score that's elevated, they'll put you on a statin. And that statin will lower your your mortality rate. But before they do that, they got to do some kind of investigation, which is what the doctor wants him to do. Now, that can be a cardiac cath if he fails the treadmill. It can be a treadmill alone. It can be a treadmill with nuclear imaging. We're going to leave that to the cardiologist. But the point is, your husband should listen to the hematologist who's trying to send him to the cardiologist to do more tests, and go to the cardiologist, or go back to his PCP with that report and say, do you think I should see a cardiologist? The PCP might have the ability in his office or in his group to get the further testing done.
So get the information that you're being told, go and make an appointment with your general practitioner, sit down and say, here's all the information I have, and let them take it forward and get
go to somebody.
Right. So go ahead.
Well, for the further nuance of what I was trying to say is that we have these instincts. Some of them are misdirecting. Some of them are not. We're wired for. Some of them we've been trained to not listen to. They're valid. Use your instincts. Learn how to trust them better, and learn how to be around people or get information from people, whether it's a specialist here, a specialist there, or consultant, who gets you the right guidance.
All right, can I say something?
Yeah, you're supposed to.
All right, so here, let me say this, because I appreciate you guys so much, but I'm going to be the patient, because I'm going to be the patient in this question, okay?
What's your calcium score?
We went over that last week.
All right, so no, let me be the patient in it. Now,
go ahead.
I'm not officially answering the question, but if you were asking me, you're resisting it, okay, what should you do? All right, you're anxious. One, don't resist it, period, end of story. Don't resist it. It's okay to be anxious. I've been there. Went to the doctor said we haven't done an EKG in a long time. So they hooked me up, with, everything. And the little paper printout, and the doctor looks at me and says, I don't like this little blip here. I want you to go see a cardiologist. I don't want to go to a cardiologist. Now, I will tell you this. For me as the patient, I think that's a scary moment when a doctor finally looks at you at that age in life and says, I want you to go see a cardiologist, because that, to me, that's what you don't want to hear, okay? So I said, okay, I got a second opinion on the EKG. Second doctor said, go see a cardiologist, okay? So I went to a cardiologist, and I had the nuclear stress test, okay? This is anxiety, so the cardiologist says, I went over it. There's something I see there that I really need to go look at. What's that mean? A cath, right?
Yeah, I say.
So the next thing I know, cardiologist says, I need to go in. You need to go in where? Where do you need to go in? I need to go in your heart. Yeah, hell, you say. Excuse me on this, okay?
You're sounding anxious, Brian.
So wait a minute. That's all right. So I said, okay. All right. So I go for this. And they come in and they bring me the paperwork and they sign it. And it comes in. He says, here's what we're going to do. We're going to go back here. We're going to do this, that, and the other thing. He said, if I see something and I got to put stents in, I'm going to do them right then. Okay? So we're going to go and look. So we go in there. And I'm actually watching. I'm like, when am I going to? But I'm actually watching on the screen, but I don't know what he's looking at. I come out. I'm laying there. At about an hour and a half later, he comes in and says, "Hey, you're going home today." He said, "I see a little bit here, but nothing that concerns me." And I didn't have
home on a statin.
I don't have to do no stents. He said, you're going home. He said, and we're just going to put you on a statin and maintain it. It is something. All right, so I hope I didn't take too much time, but go to the cardiologist, okay? Go when they recommend, not when it's no longer your choice if you go.
That's right.
Right?
Yeah.
So did I do okay on that?
Okay, now, one more thing.
Now, I was anxious.
Yeah, okay.
I have to admit.
This is a cancer-sponsored program, and I want to tell you, we're going to ask Corey, what's the first symptom of coronary heart disease, Corey? Shaking his head. 50% of the time, it's sudden death. Heads, it's sudden death. Tails, it's fatigue, chest pain, feeling of impending doom. So you don't want to be in that 50% that's tails. You want to get this diagnosis made, and maybe this anxiety is your way of having the feeling of impending doom. This is probably coronary disease. All right.
Well, I just want to say, just on that again, when you're told go see the cardiologist, because you put it much better, because the next thing's possibly the coin flip.
Okay, well, let's talk about the male aspect. The male aspect is that my body fixes itself, and I take better care of my truck than my body. So Bill talks about the beauty of the body is that you have two things, and you can look for asymmetries. In this situation, you look for, do I have brothers, uncles, dads, moms that dropped dead or had heart attacks at a young age? If you have those risk factors, you need to know about your
And we don't
heart.
know that from the question.
We don't know that from the question. But guys don't ignore this, and if there's risk family members, follow their lead.
Right, go get the calcium score. But this guy's already got the calcium score, so he
Well,
needs
the
to
end of
follow
that, and I hope I didn't upset you out there, but the end of that is he is resisting. What do you think he should do? So I'm not the one here in the morning to answer those questions, but I have actually gone through what this gentleman is going through from the anxiety and from being told go see a cardiologist. So I just
So follow his advice was the answer from all three of us.
Go do it.
Wow, 3 out of 3, that's pretty good. Even Corey's nodding his head over there. All right, this next one is an interesting one because what's sauce for the goose and the gander, everything's not always the same. My question is about my brother who had blood clots in his legs that the oncologist blamed on hypercoagulability. See, that's why I wanted to read that one for you.
Yeah,
so you didn't have to read that.
No, I can't do
hypercoagulability due to cancer. Now, we have not talked about this in a couple of years, but we have. We talked about that guy who had the clot under his clavicle, but that from the testosterone, but that was not from the cancer. All right. He has him on an oral new type of anticoagulation. Okay, that sounds like the right thing to do. I had a clot when I was pregnant, and they had me take a shot to anticoagulate me during that and subsequent pregnancies. That tells us something. She probably had also had some fetal wastage, may have had some miscarriages. The very next line tells you that she did. I had a positive Leiden blood test. That's a genetic disorder we've talked about before that makes you have blood clots even though you're not flying in an airplane or having a surgical procedure. And he did not have that test. He did not have that result. So he has a negative factor V Leiden, but he has a hypercoagulable state because of cancer. How is that, and what should he be doing? He's not as confused as I am. Well, what that tells you is that it's not that the parents weren't homozygous, meaning they didn't have 2 copies of the gene, and you got it and he did it, and that's because you got 1 gene from your mama and 1 gene from your daddy, but your brother isn't you. So you've got different genetics. That's the important thing. Your brother's not you, the genetics are different, and his hypercoagulable state is not due to pregnancy or birth control pills plus factor V Leiden. His is due to having cancer. Now this is going to be quick and easy, but we're going to put that next one up. So we're going to talk a little bit about the pathogenesis of hypercoagulable state associated with malignancy. You want to read that long thing there? Pull that down. Now, the easy part, this you got the next one up there? We talked about chronic lymphocytic leukemia, that's a malignancy. We've talked about that Merkel skin, well, lots of things are cancers, but the risk factor that is the biggest one is what kind of cancer do you have? And at the very top of the list are pancreas and stomach, very high risk for clotting, and then high risk, and that's lung, bladder, testicular, GYN. Pull that down. Now, Ray and I are older than we were taught physical diagnosis, okay? Most present medical students spend very little time on physical diagnosis, listening to heart murmurs and learning what the association of ridges in the fingernails are, psoriasis and stuff, because they all are looking at computer algorithms and how to interpret genetic testing, but physical diagnosis is still there, they just don't do it much. Well, there was a condition when we were in medical school called Truso Syndrome, which was a blood clot in somebody who didn't have any reason for a blood clot, and that was associated with pancreatic cancer. So back in the days before CT scans, there weren't any CAT scans or x-rays, there weren't any blood tests for pancreatic cancer. Somebody who had blood clotting for no apparent reason would go down a pathway of diagnostic tests to see did he have Truso syndrome or a malignancy in his pancreas or lung.
That brings up an important point about our education nowadays, but if I've got an unexplained blood clot in a patient, I always work them up for an occult malignancy. Is there malignancy in this patient that we don't know about yet?
Right.
And I always have an argument with the insurance companies because they don't want to pay for certain tests on, quote, a whim. Well, my experience is if you've got unexplained blood clots, there's a high risk that you'd have of having cancer, and we need to go looking for it.
Yeah, or the factor V Leiden like she
yeah.
had, or one of those coagulable tests. So we're going to look at this next one because this was the bane of every got it up there, blood coagulation cascade. There is not one medical student in the world who didn't have trouble remembering this thing and spitting it back during physical diagnosis. But this is for the blood to clot. When you get a little cut up here, 9 to 11 things got to happen, and a bunch of dominoes got to all fall over, and all those dominoes got to be in the right place. That complicated looking thing. Mm-hmm. And the anticoagulants work in different parts of that. So pull that down. Remember the rat poison everybody took? I took Coumadin, and stick your finger, and that's and the pellets that you put out to kill rats is the medicine that we still take if you've got mechanical heart valves.
We overdose them on Coumadin.
Coumadin or warfarin. So you're overdosing the rat, and actually that stuff they have to put something in it to keep your dogs and your squirrels from eating it that they won't like, but rats do like. So it's kind of complicated. But put up this next one, then we'll pull it up, leave it up there for just a minute. Now, I always say God makes us have lots of protections. So in the normal, you got it up there? In the normal person, I want you to imagine that I hit you in the hand with my fist, and you get a big bruise, okay? You are going to immediately start clotting where I hit you. That's the bruise. And then right beside it, God's going to start dissolving that clot so that simultaneously coagulation begins while dissolving begins in an effort to heal the bruising. Pull that down. So frequently when we have somebody that gets a blood clot and we put them on anticoagulation and we go back in 3 months before we stop it and do another ultrasound, it will say the clot has dissolved or that it has canalized and it has flowed through it. Sometimes it doesn't, and you're left with chronic venous insufficiency. But the anticoagulation does not dissolve that clot. God dissolves that clot with this fibrinolysis business going on here. And that's sort of what happens in cancer, is that part of the cascade and the balanced homeostatic mechanism doesn't work. So throw this next one up here. Thromboembolic disorders in pregnancy is what this lady had. Pull that down now. And we're going to do this really quick. Don't put the next one up. When a woman has had, let's say she's had 5 pregnancies and 4 of them ended in miscarriage and 1 was successful, there's got to be a reason. And frequently, when the high-risk gynecologists start doing testing, they have a positive blood condition that predisposes them to clotting. And the fetal wastage is due to the fact that in the placenta, they begin to get some sort of coagulation that then the placenta can't support the infant and it is miscarried. So put that next one up there. This is really short. But they're talking about anti-partum management. That means before you delivery, and postpartum management in patients who have this risk. And it's a complex issue, but the Coumadin and those things can cross the placental barrier and adversely affect the fetus, but the injectable anticoagulants don't cross the placenta. So pull that down. So the decision about giving a equally effective, these two things are equally effective in rare, but they're have an adverse effect on the outcome of the pregnancy, not on the clot. So that's the reason that the woman got shots and not pills. So throw the next one up, then we're going to quit. I showed you that big old complicated cascade of what makes clot. There's lots of ways you can treat clots. This over here is the injection. This over here is the new pills. There's the stockings you wear for chronic venous insufficiency. Pull that down. You don't need a vascular surgeon. Your primary care doc can do this after the clot's been taken care of and you figured out why you did it and whether you need long-term anticoagulation or not. Then you're back in Ray's office and you've got chronic swelling in your feet and you get discoloration from chronic venous insufficiency, and this can go on forever. So you really want to prevent that clot, because once you've got that clot and it doesn't dissolve, it is a lifelong PCP problem. Take the ball, Riley.
Well, I mean, there's a new thing on the new kid on the block. Patients who've had COVID or while they had COVID, and some patients who've had the vaccine are hypercoagulable. One of the more deadly parts of really sick patients on COVID was that they had blood clots. We learned that early on and started treating it. So there's another whole dimensionality to hypercoagulable states that's associated with COVID that we're still learning about.
And today, this morning, the Johnson & Johnson vaccine
Got yanked
because it has recommended not to be given to anybody unless there's no other vaccine available to them because of the adverse number of people who had coagulation complications. Now, we have been talking about this for 2 days. How long we had the vaccine? 18 months?
Yeah.
2 years, close to 2 years. We've been talking about this, and there are the number of adverse effects that have occurred from the vaccine are far outweighed, and I'm not going to let anybody argue with me, by the number of lives that were saved. Because you've got all of these high-risk people. But going around and giving that Johnson & Johnson vaccine to some kid that's under 5 years old, or some high school kid, or some healthy person, I never believed in it at all, and today they took it off the market. Excuse me, they did not take it off the market. It's still there if there's no other way to get a vaccine.
I don't know if that should be an option. If there's no other way to get a vaccine, let's go with this one here. Thank you.
You want to get the Chinese one?
Let's not go into vaccine. Georgia Cancer Specialist, Northside Hospital Cancer Center. We appreciate you for this segment. Ask the Doc. Okay, what you got?
All right, well, first of all,
news of the day.
Yeah, all right. Well, I was just showing this. The London Burger King is trying a meatless menu for a month. How about that? Is that pretty good here? What was really interesting in this was, and I had Ray investigate it, is that it says that the fourth shot, second booster, has so much lack of confidence among the medical profession that they wrote a real complicated article. I'm not going to try and break down the whole complicated article, but they interviewed 2,000 physicians and nurse practitioners and PAs in primary care practice, okay? All of whom were enthusiasts for the vaccine. So they are the ones who recommended you get the first two and that you get the first booster. These ones all had recommended the first booster. And now they're asking them, what's your recommendation about the second booster? Only 27% of that group had any confidence that the second booster was of benefit, meaning roughly 75% of them were skeptical. That's the group of people who were enthusiastic about the first booster. Now, if you go back to people who were not enthusiastic about the first booster, but said, yes, high-risk people take the immunization, that number that was skeptical was even higher. So my good friend Steve, he's had the fourth booster. He wants everybody to get the fourth booster. CDC and the American Society, what do they call it? American Association of Infectious Disease. They all recommend the fourth booster, but they haven't convinced the great unwashed, I guess is the way to put it.
Well, it's an interesting historical point, though, because I don't, over my lifetime and yours, I don't know of our profession ever turning on a drug like this. I mean, vaccines there's always been people who are resistant to vaccines and the notion of them, and that's always going to be the case. But pretty much in the medical profession, people learn about a vaccine, physicians and providers, and encourage and use it or recommend it. That's not the case with this one. For one reason's obvious. We're dealing with a pathogen that's changing, morphologically adapting and changing, and so it's dodging the vaccine
Much faster than the
much
flu
faster
did.
than the flu and anything else. And that's just nature. So there's a simple explanation is that the virus is dodging the vaccine, so why would you think the vaccine, which is static, is going to keep up with it? Then there's the whole second thing that you have an industry now that was hiding information from the medical community, and that's absolutely taboo. And so there are a lot of folks, myself including, that says, well, if you're going to hide something from me, then I'm not recommending it until I find out what you were hiding. And that's just me. So, and they're going to have to come clean about it, and there are a lot of people dragging them, kicking and screaming out into the light, and we'll see what comes of that.
Well, obviously Johnson & Johnson got drug out into the light.
Yeah.
So anyway, there's a lot more stuff. Interestingly enough, the news of the day, this thing comes out at about 3 o'clock in the morning. And you remember that it's about 5 years we've been doing this.
Yes.
You remember for the longest kind of time we were talking about
We've been doing this so long, I think I've seen two ties twice.
probably this one. All right.
Just
so
joking.
basically,
He has a lot of ties.
we used to talk about the danger of packaged romaine lettuce
Yes.
versus fresh romaine lettuce that you could wash and the associated bacteria that was with it.
Yeah, in the
Remember
good old
when-
days, we used to talk about washing
Remember-
and prepping
Yes,
food,
about-
right?
Yeah.
To keep down food poison, and
It was
when
food-
you travel, we used to do that in the
food
good old days,
boils.
right?
Remember when we had a Zika update?
I was just getting ready to say, whatever happened to Zika? Zika packed and
Bill,
left
that
out.
reminds me of the guy who went to Burger King and he said he wanted minimum lettuce on his hamburger, and the little girl said, "We don't have minimum lettuce. We only have romaine lettuce."
I told you to have a joke today because we were gonna have easy questions now. Go ahead.
I do have a newsworthy
Well, we're not up to
serious
jokes
thing.
yet, are
No,
we?
it's not jokes. This is not joke. This
Newsworthy.
is serious.
Okay.
Well, I mean, the thing in the news is the Supreme Court
Yes.
issue, and you and I talked about this when we had me alone one time, and I wanted to elaborate on it a little bit. Medicine, our field of medicine, is an incredible endeavor with some incredibly bright people who do amazing work.
Yes.
One of the things that happened in the middle of the last century, in the middle of the 1900s, is birth control was finally understood. It was cracked. And the development of birth control pills came out, which probably was one of the most revolutionary, liberating things for women in the history of being a woman. All time. It gave and empowered women to control or have control of their childbearing period of years. When am I going to have my babies? How many babies am I going to have? How am I going to space them? I mean, you think about the social revolution that brought about as a technology, okay? Well, what could be more evil than dovetailing right in there beside that? Yeah, but we're going to do abortions, okay? Instead of controlling and teaching and empowering women to have control of their bodies, it's like, you can be out of control and just go kill the baby. And now you have this whole, quote, women's lib, women's right thing, which is the opposite of women's lib and women's rights, because it's not empowering, it's not educating, it's not disciplined. It's like, no, you screwed up, go kill the baby. Well, two things.
It's like a get out of jail free card for DUI.
Yeah. And this is why I call it evil. It's the good is to give somebody strength and power and control. The bad is be out of control and there's no consequences to it. Well, I don't know any women that go through an abortion that aren't emotionally scarred by it. I'm sorry, they're scarred by it.
Yes.
People that experience that and go through that, it's a hard decision. It's a painful decision. It's a lonely place, and you think about it the rest of your life. So, why is it that you got people promoting this deadly, arcane, primitive, medieval thing of killing babies as though it is God's gift to women. No, God's gift to women was men and women, scientists figuring out how to do birth control.
Dr. Greenblatt, who was one of my co-authors, by the way, was invented birth control.
Yeah. So, I mean, what an powerful thing. So, and then the second piece of it is, and I'm kind of waxing philosophical here. If you think about slavery, the evil of slavery, which millions of people believed in, they believed slavery was okay, that it was okay in the Bible and it was okay to do this. There was this notion that that group of people were property, and they were your property, and if they were on your property, you controlled their lives, and if they needed to die, then you got to decide they died. That's how evil that was, and millions of people thought it was okay. Is it not the case that a baby is in a lady's womb? It's inside the lady. It's part of the lady's property. And abortion says, well, until that baby's out and on its own, it's your property and you get to decide whether it lives or dies. Equally evil. And I think 100 years, 200 years from now, we will look back at this and say, what a disgusting, terrible thing to treat living babies as though they're property that a woman gets to decide the life and death of because it's on her property.
All right, so let's stay with this just a minute. We got to get out, but I don't want to get out without staying with this. This is a great conversation because I sit with you two every Friday.
You did say no politics.
No, this is not politics.
Okay,
This is not politics. I sit here every Friday with you two, and we talk about saving lives. Mm-hmm. We talk about what we could do to save a life.
Right.
With you two guys, okay, physicians. And when I think of my doctor, I go to my doctor, and I think of health care. I think about what can you do to save this life or whatever.
I can answer where you're going with this.
Wait. And then there's like when we get up to this line now on abortion, I get confused on how they continue to call that women's health care. How they consider
or family planning.
But how is that now? Wait a minute. This field is dedicated to saving lives, ending lives. And one more thing. I'm going to get out. So recently we've had infanticide, which you can go into that if you want. We have the morning after pill, and now they're going to ask, maybe through executive order, for the FDA to waive some restrictions on an abortion pill, not a morning after, pills that are designed to abort the baby and then sell those across state lines.
It's complex medical decision making, but let me jump off the point the bigger point that you made, and I can say this and ask Bill if he's the same. I didn't have any classmates that intended on or aspired to go into being an abortionist. None.
Zero.
It's not something we went to medical school for. And so the very nature of my profession, I don't know how that's taught or how it's inclined for. So, and you're the same? I mean, I didn't know anybody.
No, me either.
So.
And by the way, most of the people that are doing abortions in abortion centers are not OBGYN doctors. It's not like going to your local.
There's not many of them, and they're not respected. I'm sorry, they're not.
Yes, but you've got 5 or 6 obstetrical and gynecologic physicians that practice in this area up here, and they are not going off to some clinic somewhere and working on the weekends doing these procedures. It is a tiny little group of misguided, misdirected people, in my opinion, that have focused their life, probably for the economics of it, on doing this simple procedure that kills people.
And I want to be in this on a positive, okay? The right of a woman to have control of her life is critically important. It's very valuable, and it is solved through birth control done properly. Okay? That should never be taken away from a woman. End of statement.
You got anything else? Or
no, it's intense.
Where's the joke?
I'm still looking for minimum lettuce. I'm going to try that on my next sandwich. So.
Next sandwich, minimum lettuce. Okay.
All right, so thank you very much. This is Georgia cancer specialist affiliated with Northside Cancer Institute, who has put on this wonderful discussion about minimum lettuce. That was just wonderful.
Thank you for the questions, and I tell you what, it's just an honor to sit between these two guys and listen as they go through these questions and answer them for you every Friday. I appreciate them. We know you do. Keep the questions coming. We're going to take a break, and we're going to come back. The All-Star Political Panel is here.